Welcome, Lars, and welcome, Shelley. Thank you so much for joining us this evening for this inaugural debate for the EDBTA webinar series. We're very lucky and privileged to have you both here this evening to be talking about this important issue of how to manage self-harm in treating borderline personality disorder. So I'll just begin by introducing you briefly and then talk a little bit about the setup for this evening's debate. So first to say, Lars Mehlum is a psychiatrist and professor of psychiatry and suicidology and director of the National Center for Suicide Research and Prevention at the University of Oslo in Norway. His main fields of expertise are suicide research and prevention, psychotherapy research, and research into people with personality disorders and traumatic stress syndrome. Dr. Shelley McMain is head of borderline personality disorder of the Borderline Personality Disorder Clinic and a senior scientist at the Center for Addiction and Mental Health in Toronto, Canada. She also serves as director of the Psychotherapy, Humanities, and Psychosocial Interventions Division and is an associate professor in the Department of Psychiatry at the University of Toronto. In addition, she is the founder and co-director of the Center for Mind-Body Health, a private psychotherapy practice in Toronto, and she currently serves as past president of the World DBT Association. So thank you both for being here, and we're going to benefit, I know, from your rich experience. I'll just talk us through this the format for this evening, as it will be very different from what you have seen on other webinars, as our two guests will attempt to engage in a lively debate on the topic of how to treat self-harm. And so what we'll be looking at here first then is just some orientation slides here. And the format of the debate is that Lars and Shelley will each have the opportunity to make opening statements about the motion. And then there'll be a clinical vignette, and Shelley and Lars will discuss what they would prioritize in each session and why. Then there'll be 2 rounds of arguments, followed by a rebuttal round. And then finally, you all will have the opportunity to ask questions. So we'll have very ample time for questions and answers. And so please send those through on the YouTube channel. There is an opportunity, there is a space in which you can ask questions there, and those will be sent forward to me to read out and have answered for you at the end of the debate. So just to be clear here, what our motion for the evening is: in the treatment of borderline personality disorder, self-harm does not need to be directly targeted in every time it occurs in order to achieve good outcomes. So we're really getting at the heart of DBT, that all of us who have been trained since 1993 have been told this is the first thing you must treat, and you must treat it in every session to have an adherent session, or you must treat high urges to do this behavior. And so it'll be very interesting to see all of the new research and all of the new data that has come, and to hear from your expert opinions or expert experiences even about this motion. So I will turn it over to you now to start with you'll each have 5 minutes to make your opening statements, and we'll begin with Lars making his opening statement. I will share the timer with you now, and please begin.
Right.
Can you see that? Yeah, please begin.
Thank you.
And you're off.
Thank you, Amy, for these kind words and sharing this session. I think actually I have to clarify, the self-harm doesn't have to be covered in every session in DBT with people with borderline personality disorder. What we know is that Marsha emphasized very strongly a recommendation that when self-harm behaviors do occur, they are always discussed in the next individual psychotherapy session. Actually, it's defined by her as a crucial aspect of DBT. And she even said that Non-compliance with this requirement is a therapy-interfering behavior, at least when the therapy is DBT. So, I just wanted to share a few thoughts about the what. What are we required to do? And the how and the why. So the what is, of course, that even though nobody likes to discuss self-harm behavior, therapists hate it and avoid it often, and patients don't like it either. They may like to discuss, for example, emotions and problems associated with self-harm behavior, but they don't really want to enter into a discussion moment by moment of the behavioral and environmental events that led up to and followed the self-harm act, right? And then to generate a list of behaviors that could substitute for that kind of behavior. That's not what they want. But even though I know that all you and all who have been trained in DBT, you have a toolbox of strategies, behavioral strategies that you could use in order to reduce or eliminate self-harm, such as, for example, determining what prompted the event or the self-harm behavior, or what is actually maintaining this behavioral pattern. And then, for example, withholding those reinforcers that follow the behavior. So one aspect of this could be, for example, to put self-harm onto an extinction schedule. There are many more opportunities. This is a great part of this treatment to offer to the patients. I could also actually mention many more. For example, sometimes it's not only trying to extinct the behavior, but also sometimes adding aversive consequences with care in order to not reinforce these behaviors. So for now, that would be some of the how. And then why? Why is this so important? Well, Marsha did not have all the data we have today, but even so, she designed this treatment because I think she inherently she knew how important this behavior is in the maintenance of the symptoms in general in people with borderline pathology. Now we have data from prospective studies that shows us that ongoing self-harm increases the likelihood and severity of self-harm over time, and also the likelihood of suicidal behavior and suicide over time. And we know, conversely, that early remission of self-harm behavior in treatment is predictive of strongly improved outcomes in many types of outcomes, particularly in emotion regulation capacity over both short-term time perspectives, but also on very long time perspectives. Actually, we just recently published this very long follow-up study of adolescents who had received treatment as just 14, 15 years old, and now as adults. If they had this early remission of self-harm quickly or within 1 year after the treatment, they had a significantly higher emotion regulation capacity as adults, which is something Marsha didn't know. But intuitively, I think she knew that this needed to be addressed very early. So we know also from other studies how important it is to achieve that kind of behavioral change and replace self-harm behavior with more functional behaviors in order to achieve real improvement. I think my time is up for my initial statement. Thank you.
Amy, we're not hearing you. You're on mute.
I was just saying, Shelley, over to you.
Okay, well, it was very nice background music. So thank you. Okay, I don't know if I should wait till you set your clock or you've already done so. I guess so. The clock is running. So maybe I want to begin by being really clear at the outset. about what I am and also what I'm not arguing. I'm not arguing that self-harm or suicidal behavior is unimportant. So on that point, I absolutely agree with Lars. I'm also not arguing that safety should be minimized or ignored. And I'm also not arguing against the spirit and the values of DBT. My argument is a bit narrower, and I believe it is fully consistent with DBT, at least as it was intended to be practiced. So my view is that it's the insistence on targeting self-harm every time it has occurred isn't necessary to produce good outcomes. DBT has given us this terrific target hierarchy. It really helps therapists prioritize, in moments of complexity, what to address. And certainly under the current adherence standards, if self-harm or suicidal behavior has occurred since the preceding session, or if there's been an increase in 3 points and urges, therapists are expected to initiate a protocol that includes conducting a chain analysis of the episode, problem solving the episode, obtaining a commitment to not engage in further self-harm, and to troubleshoot the plan. And if you miss any of these steps, it would be considered a downgrade in adherence. And Linehan outlined why this mattered, which I think is important. She argued that certainly non-suicidal self-injurious behavior is a predictor of suicide risk. Self-harm does carry an accidental risk of death, and certainly self-harm can interfere with life worth living goals. She also argued that therapists, by refusing to condone self-harm, would be communicating care and commitment. And I think her approach was historically transformative, and it emerged at a really important time, in that there was a time when patients who were self-harming would be excluded in some cases from treatment programs. And so I think what was really important is that DBT insisted that self-harm needed to be taken seriously and needed to be addressed directly. I think that's a compassionate approach. So my concern isn't so much with Linehan's rationale, but rather how the rationale plays out in practice and how it contributes to really rigid, automatic, and inflexible responding rather than context-sensitive clinical judgment. Yes, self-harm can be a predictor of risk. Just because a behavior tells us something about risk doesn't mean that it necessarily need dictate what we target first. And I think the target hierarchy itself is not a mechanism of change. DBT has always emphasized understanding and addressing the function of behavior. So targeting the function of self-harm rather than repeatedly prioritizing the behavior itself, I think can be a more efficient and effective way to reduce self-harm and suicidal risk. Certainly accidental lethality is a real concern, but it's not a substitute for a nuanced risk assessment. DBT clinicians are trained to assess severity, imminence, risk patterns, and not all instances of self-harm reflect high or escalating risk, and treating them as they do can undermine efficiency and distort clinical priorities. Similarly, the argument that not condoning self-harm might reflect a genuine therapeutic value. I think it's important that we appreciate clients have different social learning histories, and people respond differently to how care is going to be communicated. And a rigid response may not always function as care for a client. So what I'm advocating for isn't abandoning safety, and it's also not abandoning DBT, but rather a flexible, function-based application of the hierarchy that's grounded in proportionality, that takes into account an individualized assessment of risk and good clinical judgment. So this debate for me, it's not about rejecting DBT foundations, but it's about practicing DBT as it was meant to be practiced, with flexibility, precision, proportionality, and clinical judgment.
Thank you. I don't know how to make the music stop without letting
It's
it go
easy.
for its five
Great,
seconds.
it's great.
Excellent opening here. And now, thank you very much for that. We're going to move on to thinking about a clinical case. And I'm just going to share with the audience the details of the clinical case so that everybody is with us here. And this is what we're looking at. The relevant data here, the historical data about the case that we're thinking about is that this is a 28-year-old woman with a diagnosis of BPD. She has a 10-year history of cutting, mostly with low lethality, although in the past year she's required sutures. The current frequency of self-harm is about 1 time per week. She's made no suicide attempts in the last 4 years. And the usual pattern for cutting seems to be an interpersonal rejection leading to shame and abandonment, which then is managed through the cutting behavior. In the session that she attends, she presents to the session with a completed diary card, which on the diary card reports 1 episode of self-harm that occurred last night. She appears in session dysregulated and fearful that her partner will leave her, sorry for the spelling error, because they had a fight last night during which he threatened to end the relationship. She says, "I don't know how to survive these feelings. They were too much." And so now each of you will have 4 minutes to talk about what you would prioritize in the session and why. And so we'll begin with Lars here. And I will set my timer again here. And we will go to 4 minutes. Off you get on with that, Lars. Thank you.
Okay, thank you. Great case. I'm sure a lot of all of us, we recognize this as a very, very frequently occurring situation. Now, unless there was something else in the information than what you listed, I would not prioritize safety here. I would briefly ask the patient how she was feeling, if she felt suicidal. This would be in the course of an ongoing therapy, I would revisit this issue, but if nothing came up in that domain, I would not go there at all. I would instead validate the patient for coming in and for being willing to work with me, even though she was so upset. I would also validate her emotional situation, how hard it must be for her to have had this experience last night. I would also regret that she actually self-harmed instead of, for example, using skills or calling me to have some coaching in order to use some more functional skills. But I would say that I'm glad that she's now safe and that we can now work. And I would ask her to join me in a behavioral analysis of what was prompting the event and what was the consequences. Of course, some of it already we know. We know what the scenario was. But again, I would remind her that in order to change this pattern, she very well knows that she gets overwhelmed in certain situations and she reacts in certain ways and she gets even more upset. And this seems to be going on and on. And she has been in therapy some time. She has stopped suicide attempts, but she's still averagely self-harming or cutting once a week, and typically in these situations. So I would say to her that I believe that you can do it. If you and I, if we work on this and use a large part of the session today and try and generate some solutions on how to get a step further in order to reduce this behavior, then I'm hopeful that she will make progress, even though it's super hard. And I would use some strategies to elicit some of these commitments. For example, I would say something about how important it is to stop self-harming. I would perhaps share some examples. I would even share some research showing that on average it's super important for people to be able to stop self-harming, just like stopping other addictive behaviors, because this is a true addiction. It has many of the same features like addiction, and it's destroying lives. So I would say, join me and we will work. So that would be my first strategy, and I would not ignore the emotions. I would not ignore the problems, but they will be covered within the behavioral analysis. That would be the whole idea, generating solutions with this strategy.
Thank you. Yeah,
Very nice.
very nice. And over to you, Shelley. Thank you.
Yes. Okay. So in this case, we see a woman who clearly is profoundly emotionally dysregulated following this clear interpersonal threat. She's had a fight with her partner, she's threatened to leave. She arrives in session overwhelmed by shame, fear, and probably a sense of aloneness. And she says, really clearly, I didn't know how to survive these feelings. So the question is for me whether or not what's the most likely or useful approach to reducing future risk. And certainly one option would be to spend a good portion of the session or some portion of the session conducting a behavioral chain analysis of the self-harm behavior. But I think in this case, the approach is unlikely to be the most effective use of time. The function of the behavior is already clear. The self-harm occurred in a really highly salient relational context in response to overwhelming affect and fear of abandonment. The client herself is articulating this, and a detailed chain analysis is not likely to generate new information and risks shifting the focus potentially to her perceived failure, increasing shame and reinforcing emotional avoidance. Instead, I would prioritize the drivers of the behavior. Self-harm here is best understood. It's a marker of emotion dysregulation, not the mechanism that's maintaining her risk. And when the function is clear and risk has been assessed as stable and it's not escalating, treatment priorities should be guided by impact, not by habit. So what would I prioritize instead? I would focus on slowing the session down, helping the client remain present with her emotional experience. This would include increasing her tolerance of feelings of aloneness and shame, and essentially engaging her in affect exposure to the very emotions that she escaped through cutting, which will increase her capacity to stay with those emotions and reduce the likelihood that she needs to engage in escape behaviors. Second, I would explore what broke down in the moment, what feelings made it seem unsurvivable. Perhaps there were beliefs that were activated related to abandonment or worthlessness or being incapable. I'd explore whether there are specific cues that escalated her response and understand any barriers to coping, which I think is clinically more useful than cataloging what she did and didn't do. And third, I would be focusing on the interpersonal rupture directly. So the fear of relationship loss is really central here, helping her respond more effectively to this interpersonal rupture, whether that be through validation, repair, or tolerance of a rupture in a relationship, or a more skillful communication, is in itself a form of self-harm prevention. If abandonment fear is what's driving the behavior, then working directly with the fear is going to be the most efficient way to reduce risk. I'd also invite curiosity about the emotional meaning and interpersonal impact of her behavior, not to induce guilt, but just to expand her awareness and choice. And I think understanding the emotional logic would allow the client to see the behavior more clearly and open space for alternate responses. There.
Thank you. I stopped my timer, but you took it was excellent. Thank you very much. Okay. So thank you for that. And now we're going to move on to the actual argument rounds. And each of you will have we'll have 2 rounds each, and each of you will have 4 minutes per round. So Lars, you'll begin that, and then we'll move to Shelley, and I won't say very much in between. I'll just reset the clock so you'll hear the timer do its thing, and then that'll be a key to reset. For those of you who are watching, I encourage you to send in questions. I'm sure that what you've heard thus far is extremely thought-provoking. You have questions, please send them through on the YouTube channel. That would be excellent. We would love to hear from you. Okay, thank you.
Yeah, so what could be the difference between the approaches? I think I hear a lot of what I would do in what you say, Shelley, because I think that perhaps one of the errors I think therapists can do in DBT is that they actually compulsively follow a scheme and use the format instead of looking at the function of the therapeutic strategy, right? So when I hear you speaking, I hear a lot of you are looking for not only the behaviors, but also what was the feeling, what was the emotion, what led to what, and to help the patient to identify the sequence of events and also to identify possible turning points. Where could things have been different if she had been, for example, using some skills, or she had been mindful, or she had been avoiding some of the very prompting and emotionally very salient situations that she is so vulnerable to? Mindfully staying away from certain situations where she risks entering into the same, because there is not only a lot of behaviors here that are maintained by consequences, but there seems to be a lot of automatic responses too. That is nearly as a automatic response coming up like a classical conditioned response where certain things are present, she has a very hard time avoiding entering into the same loop. So actually, I think that we agree here on a lot of things. And for example, I think there is a lot of escape here. And I think that when we are following this up in the session, I think we need to be mindful as therapists that we are not inadvertently reinforcing this behavior through going too much into discussing things around the behavior that we need to change. I think actually here comes the dialectic, that we go into these emotions and sit with the emotions, that there is a certain exposure, but still also maintain the focus on what needs to be changed. So and that's very difficult when the therapist is also emotionally activated. That you stick to your schemes, and you insist on certain rules to be followed. So I liked what you said about slowing down the session. We are in no hurry because, as you said, we don't expect that totally unknown information will come out of the behavioral analysis. We have been through it many times, but in the behavioral analysis, I think we can revisit opportunities and failures to use opportunities mindfully with the patient.
Shelley?
Great. That Viennese music, by the way, Amy, it's perfect there. Okay. So my first argument is this. My position is that direct session by session targeting of self-harm isn't empirically necessary for effective treatment. And furthermore, it just might not be clinically efficient. I want to start with the science. First, we don't have dismantling evidence that shows that prioritizing self-harm every time it occurs is the active ingredient that drives good outcomes in DBT. We know that DBT as a package works. What we don't know is whether this strict, repeated prioritizing of self-harm is necessary for that change, or whether there may be other components, such as skills acquisition or emotional exposure or contingency management, that may be key mechanisms of change. So without dismantling data, we really can't claim that this episode by episode protocol is the active ingredient of DBT and is essential. Second, we have evidence pointing in the opposite direction. So trauma-focused DBT provides a really clear and a good example. Recent outpatient trials of DBT PTSD conducted by Martin Bohas and colleagues have found that patients who were not required to abstain from self-harm before beginning trauma exposure, and this is a condition that a very strict interpretation of the hierarchy would prohibit. But despite this, DBT PTSD was found to be safe, found to be effective, and associated with reductions in self-harm, not only across the entire treatment, but during the exposure phase itself. And this was true even among patients with very high levels of baseline self-harm behavior. So I think the takeaway here is straightforward. DBT can reduce self-harm without making self-harm the primary target in every session when the treatment focuses on the drivers of the behavior rather than behavior itself. And I think this research on trauma-focused DBT matters because it challenges a core assumption that you have to stabilize self-harm in order to effectively and safely move to stage 2 work on emotion processing or enhanced emotional experiencing. This finding is also consistent with the broader psychotherapy literature. There's several other evidence-based treatments for BPD, most notably mentalization-based therapy, general psychiatric management, that produce significant reductions in self-harm, suicidality, hospitalization, and improve overall impairment. These treatments don't consistently prioritize self-harm session by session, nor do we have any evidence that DBT is faster at reducing self-harm. So in fact, to the contrary, our trial comparing DBT to general psychiatric management found that self-harm rates reduced at a comparable rate. So in other words, there are multiple pathways to the same therapeutic outcome, and those pathways don't require frequent targeting of the behavior itself. Again, to be clear, I'm not arguing against the hierarchy. Nor am I arguing against safety, but I am arguing against treating the hierarchy as an automatic rule rather than a clinical guide.
Thank you. The music is completely incidental, not the Viennese was Zoom choosing it, but it works. Lars, over to you. Thank you.
Yeah, actually, I just want to clear up one thing. I know that a lot of people are confusing self-harm with non-suicidal self-harm with suicidal behavior. That's extremely important to distinguish. And Marsha made a major contribution in doing so without really having the data. But this is more and more important to maintain that. So I'm not talking about safety at all. I'm not talking about focusing on too many things at one time. Sometimes we will have to, of course, focus on safety, but this was not the debate. When it comes to can we really address the function of self-harming behavior without focusing on self-harm behavior in itself? I don't think so. I think that would be joining the mainstream huge avoidance of suicidal and self-harming behavior we see in many therapies today. And of course, you are totally right, Shelley. We don't have the dismantling studies to show nearly anything in DBT or other treatments that are indispensable or more effective than other things, that there's a huge shortage. So absence of evidence does not imply evidence of absence. That's one thing. And I would also say that we do know that DBT is the number one treatment today to reduce self-harming behavior. There's no doubt about it, even though we have one or two treatment studies comparing trials, comparing treatments, or we do have other treatments having some evidence. This is probably going to be one of the important things to clarify in the future, whether or not the evidence level is the same in other treatments. I don't know. When it comes to this idea of the speed of recovery and remission in self-harming behavior, I think the evidence today is a little contradictory. We don't really have consistent and very, very solid evidence. But I must say that one of the things that Marsha's component study would show from 2015 was that I think she concluded that the specific focus on self-harming behavior would be one of the things that would actually be covering or explaining why you couldn't find huge differences in suicidal behaviors as an outcome in that dismantling study, simply because the treatment is so focused on it. So actually, I think we should do studies like this in the future, but it is difficult because, as we know, it's difficult to include patients with high levels of NSSI behavior, and even more difficult to have suicidal patients in it. For the evidence of the trauma-focused DBT, I think actually that this is exactly what I would expect, that you don't have to insist on people refraining from self-harming behavior in order to take them into treatment. Of course, they are the target group. They are the ones we want into our treatment. And luckily, you discovered, or Martin discovered, that you don't really need to have this remission before you start the trauma.
Thank you. And over to you, Shelley.
Okay, so my position is that rigidly targeting self-harm every time it occurs is not an efficient way to engage in treatment and to use clinical time. And I think importantly, it can detract from more effective treatment of the drivers of the behavior. To paraphrase Marsha Linehan, the most important question in treatment is not what the behavior is, but what function it serves. And I think that principle matters here. And it's the rigid prioritizing of self-harm that can come with costs. So when the function of self-harm is already well understood, when risk is stable and it's not escalating, and when a repeated chain analysis is no longer generating any new information, continuing to prioritize self-harm can be procedurally correct, but it's often clinically inefficient. It's consuming valuable session time that really could be better spent targeting the processes that are actually maintaining the risk. Self-harm decreases, we know, most reliable when the system driving it is transformed. And that's basic behavioral theory, and it's entirely consistent with DBT's focus on function. So we know self-harm, it's a marker of emotion dysregulation. It's not the primary mechanism that's maintaining suffering. And it's commonly driven by chronic emotion dysregulation and interpersonal sensitivities and experienced invalidation and trauma-related processes such as shame-based self-relating. And if we treat self-harm as the primary focus, we may reduce its frequency and even eliminate it without meaningfully, I think, improving overall functioning. So the core vulnerability might actually remain untouched. And the risk is then we become clinicians that are really terrific at treating smoke, but are not that good at, spend less time focusing on the fire. And, consider a familiar scenario. You're working with a client. The client stops self-harming, but they remain emotionally chaotic. Their relationships are unstable. They continue to experience suicide ideation. They're experiencing trauma, intense trauma-related emotions and shame. And often, another impulsive behavior emerges when they stop self-harming. Probably we've all seen this. It's a kind of therapeutic whack-a-mole. So the question is, is treatment, is it really successful here? And I argue that an overemphasis on targeting self-harm whenever it appears runs the risk of treating indicators rather than the drivers. And it risks symptom suppression rather than genuine recovery. And I think we need to be careful not to mistake behavioral quieting for recovery. So my position is that treatment should prioritize targeting the functions of behavior, and that success needs to be measured more than symptom counts. DBT was designed as a principle-driven treatment, one that balances fidelity with clinical judgment. And the treatment hierarchy was really meant to be a guide, but not to replace flexibility, evidence, proportionality, and careful assessment.
Thank you. So very interesting back and forth and debate here. You'll now each have 3 minutes for a rebuttal and your closing remarks on this evening's topic. I'll just reset. Over to you, Lars.
Yeah, so it becomes very clear from this debate, I think, Shelley, that the danger that you will have a superficial strategy of behavioral modification without going deeper into what is driving the behavior and what is all of the rich information about the life the patient is leading, the environmental and the internal life of the patient and the realities that the patient is struggling to cope with. Without that, I don't think we get anywhere. But I do think also that danger can be the enemy of the good, because I think we would find that a lot of our colleagues in other schools of therapy, they would say exactly what you are saying. DBT is just changing behaviors. It's not changing people's emotion regulations capacities. It's not really changing what's going on in the inner world. It's actually, as you said, focusing on the smoke, but not on the fire. So I think there is some truth to that. It could be part of DBT practice could be that, but I don't think that is the treatment. I think that is not DBT. And my final point here is that I think, but now the neuroscientific data needs to come forward in the years to come. I mean, the imaging data on all of the neurochemical data needs to support us also in order to study the tremendous pathoplastic effect of self-harming behavior. It does something to the brain. It really changes the brain, and it actually shapes our ways of thinking and feeling. So it's like stopping behaviors that are fucking up our brains as early as possible. And I think that that is the validity of what Marsha was recommending, to focus on the stopping of this behavior. But of course, it can be done without any focus on why are people self-harming and how can they tolerate the emotions. And for this young woman, I think she has a strong message. Help me survive these emotions, and hopefully without cutting myself for eternity, because that is not going to help her be becoming better at regulating emotions. At least our data shows that.
Okay. So, Lars, you and I do agree on the point that self-harm is serious. I agree with you. I think it is serious. And that when it occurs, it should be addressed. It is a core element of the hierarchy. I think where you and I differ is the conclusion that addressing it must mean that in every session where self-harm has occurred since the preceding session, that we need go into a moment by moment chain analysis to understand the function of the behavior. So, DBT's model is far more nuanced and more functional and more effective if it's not a one-size-fits-all approach. And I think that when self-harm occurs, the task is on the part of the therapist. You've got to respond using a risk-based approach and a consideration of the function of the behavior, rather than a content-based reflex. So I also I think my point is that addressing the drivers is really what produces the real change. I also agree, you made the point, that chain analysis is aversive. But I would argue that DBT isn't built on the idea that aversiveness is therapeutic in itself. Aversiveness is helpful only if it's tied to new learning, not necessarily when it's tied to repetitive, predictable, and no longer, functionally informative, relevant information. So when a clinician is doing the same chain with a client, there's no new insights. My position is that the aversive quality really stops being productive. Furthermore, it's in an inefficient use of time. And we have very limited time in treatment. And increasingly, there's a pressure to find more efficient ways to treat people, especially given long wait lists for treatment and problems with accessing treatment. We need to figure out how to do what we're doing in a faster and more efficient way. So I guess I'll stop at that point.
Thank you both. This has been very rich and very informative, probably one of the most civilized debates that I've ever seen. As it seems that there's really much more that you both agree upon than disagree upon, but let's pick this apart and see what questions that we might have from the audience. I am waiting to see if we have a few coming through. They sometimes take a bit of a moment, but I'm wondering if both of you might comment just to begin with on whether this would be very different if it were an urge, a high urge to self-harm or to self-harm. So one question came through about urges. Yeah.
Absolutely. I would say so. Urges are totally different, and suicidal too. So suicidal ideation too.
Mhm.
I would actually, I would commend the patient, actually validate the patient for reporting the urges and being willing to disclose it, but also validate how important it was that she was able to resist the urge. Urges are, of course, important to monitor, but they are not an outcome that we would chain analyze or focus a lot on. Actually, suicidal ideation, urges to self-harm, urges even to suicide, can be, in a way, to a certain extent, some background noise. It's I would say it's important to know, but it shouldn't be over-focused at all. What do you think, Shelley?
Yeah, I think that, the first task of a clinician with their client is to figure out, is this urge a representation of some escalation of risk? Is there possibility of high risk or lethal behavior? So safety needs to be considered. And I would bring the focus back to, what are the drivers of this thought? And my focus in the session would be largely on the drivers. So I'd spend the bulk of the time there, especially if this is a behavior that's well understood. If this is a very first session with somebody, I don't know them, they don't know me, my approach would be a bit different. I think it would be important to better understand collaboratively with the client, what is it that's driving these thoughts?
Yeah. Thank you for trying to get the questions for us. So one question that I was struck with here is this idea that once we understand the function of a behavior, then we would, we would want to kind of be treating the function of the behavior. And one could almost envision that you might redo the target hierarchy to talk about functions as opposed to discrete behaviors. One could see that, but I'm just thinking about many of the new therapists that I'm teaching, and one of the things that we're always struggling with is this notion of don't assume, assess, don't assume. So, any kind of tips on if somebody were to, how would we know that this behavior isn't serving multiple functions and that we've understood? Like, is there an indication for both of you that you say, okay, yeah, we've got this now?
No, you can never do that, because that's the main reason why some element of a behavioral analysis needs to be conducted, simply because you cannot know that. Self-harming behavior, we are now only talking about self-harming behavior, right?
Yeah.
It comes from 1 million origins, and it could be new things or in new forms. And for a patient, it can be very overwhelming and chaotic, and actually could be really important to revisit once again what really happened, to straighten out what was it and what wasn't it not, and what was it not. So yeah, I think that is, I think, Shelley, that you and me, we agree that you don't always need to use a half an hour on a behavioral analysis. It could be that you can do it quite quickly. But I think an element of that should always follow when there has been an episode. So yeah, so that would be, I think, really important always, since you can't know the function of the behavior without examining it.
So maybe my position is I'm not arguing against the use of behavioral chain analysis. I think it's a terrific tool. I think it does help a client and therapist gain insight into what's controlling behavior. What my position is rather, we don't need to chain every instance of self-harm behavior. And I think when a behavior, the function of a behavior is well understood, I think it's an inefficient use of clinical time. And I think that the time could be better devoted to actually treating the drivers of the behavior. So that's my position. Not that it's never useful, and I agree that there is always risk of therapists, drifting or perhaps not fully understanding the function. But, drift and clinical judgment aren't the same thing.
Mhm.
So,
Would there be some indicators that you would have in your mind that, okay, I've understood the function of this, I don't need to go through this again? Would it be asking the client, was this very similar to what happened last time? Or, I appreciate what you're saying, Lars, that it would be doing some aspects of the chain analysis from your perspective to get a bit of information. But for you, Shelley, when you're thinking about this, what might be some of the indicators to you that, okay, yeah, I've got this? Like, is it frequency of having done a number of chains that were similar, or what in your clinical assessment, how would you know? Like, I've got this, I understand this function.
Yeah, and certainly one of the things I learned in DBT from Marcia was that after you've done, upwards of 8 to 10 chains on a particular behavior, you will have a good understanding of what the functions are, what the drivers are of behavior. And you should be focusing on those common controlling variables. So I think oftentimes when you're working with people and they have engaged in repeated behavior and you've understood it through chain analyses, understanding that behavior, oftentimes it may just require the therapist to simply check in with the client. It might be a validation. It's like, ouch, it looks like those feelings of loss got activated again. And it may be just moving right to those drivers rather than going through a chain.
Thank you for that. Yes.
Amy, let me just comment. I do think that the greater picture can emerge, but I think also that studies we have done, when you really go at length to ask people what was driving this, why did you do it, then actually comes up a lot of things, a lot of many different things. It's not just one thing, it's a sequence of things and a complex picture. So I think that although I totally agree with you, Shelley, that you get the greater picture, I think we as clinicians should be very careful not to communicate that we got you. I know now what's going on in your mind and why you did it. I think actually we should do the opposite. I can't read your mind. You have to tell me what happened this time. We don't necessarily have to use a lot of time, but you need to ask that question, I think, simply because this is an existential question in a way. It's hugely validating to know that your therapist is always inquiring what's happening now, in the here and now with me.
I can respond to that point. Sorry.
Yeah.
We have 2 minutes left, so and now it's getting good, right? We've got
So my
coming
only
through.
response to that point, Lars, and I remember Marcia teaching this when I originally learned validation, is the importance of being able to validate what's not expressed directly. We don't need to spell it all out. When you really are understood, and actually when a therapist truly actually understands what's driving behavior, just actually being responded to your therapist actually understanding, they've seen the pattern and naming that is a very powerful way to validate.
So the functional validation of getting on
Absolutely.
it and solving and teaching the skills. We
Yeah.
do have some other questions, so you're just going to have to come back another time, but we're out of time. It has been a pleasure to be here with you. Thank you both so much for sharing your knowledge and your experience with us. And on behalf of the EDBTA's Dissemination Committee, I and the whole EDBTA, we thank you so much